Hello and welcome. My name is Adam Chu, and I'm an Assistant Director at the Suicide Prevention Resource Center. Thank you for viewing this recording. This panel discussion focuses on evidence-based treatments for suicide prevention and features 4 experts who will share their perspectives on treatments, thinking about treatment outcomes, challenges to spread and scaling, and some ways to better prepare clinicians and systems to provide evidence-based treatment. Before that, I will share a bit about the Suicide Prevention Resource Center. The Suicide Prevention Resource Center, or SPRC, is funded by a grant from the Substance Abuse and Mental Health Services Administration, or SAMHSA. The views, opinions, and content expressed in this product do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, U.S. Department of Health and Human Services, or SAMHSA. The Suicide Prevention Resource Center fulfills its goal of advancing the national strategy for suicide prevention by building capacity and infrastructure for effective suicide prevention across the country through training, consultation, and developing resources for a variety of settings, from states, tribal communities, and health systems, and that reach individuals across the lifespan. SPRC also fosters key national partnerships that engage a wide range of interested parties and also serves as the Secretariat for the National Action Alliance for Suicide Prevention. SPRC also acknowledges that the land that now makes up the United States of America was the traditional home, hunting ground, trade exchange point, and migration route of more than 574 American Indian and Alaskan Native federally recognized tribes, and many more tribal nations that are not federally recognized or no longer exist. Before we go on to our discussion, I want to highlight the importance of a systems-level focused suicide prevention effort in healthcare settings. The Zero Suicide Framework is a comprehensive approach that brings together effective and data-informed suicide care practices with the goal of standardizing how healthcare systems support people at risk of suicide who are in care. When implemented together, the 7 core components of Zero Suicide, which are lead, train, identify, engage, treat, transition, and improve, can help ensure that systems are designed so that providers are equipped to provide care and instill hope so that people at risk of suicide are supported in lives worth living. Turning to today's panel discussion, systems implementing Zero Suicide often face challenges with the treat element of the framework, which is all about providing evidence-based treatment focused on reducing drivers of suicide ideation and attempts and deaths. I'm joined by 4 experts, Doctors Greg Brown, David Jobs, Shireen Rizvi, and David Rudd, each representing different areas of treatment expertise. Dr. Jobs, would you briefly introduce yourself, perhaps by sharing your organizational affiliation and your particular area of treatment expertise?
Sure. I'm Dr. David Jobs. I'm a professor of psychology at the Catholic University of America in Washington, D.C. And I've been in the field for many years. My area of emphasis has been in clinical suicidology, assessment research, and then in more recent years, treatment research. And I'm the developer of the collaborative assessment and management of suicidality. And we have a number of clinical trials that are currently underway.
Great, thanks, Dr. Jobs. And how about Dr. Rizvi next?
Hello, my name is Shireen Rizvi. I'm a professor of clinical psychology at Rutgers University. I trained and received my doctorate under Marcia Linehan at the University of Washington. And since that time, I've spent my career researching dialectical behavior therapy across many different populations and settings.
Thank you. And how about Dr. Rudd, you're next?
Yes, David Rudd. I'm a professor of clinical psychology at the University of Memphis and one of the creators of brief cognitive behavioral therapy for suicide prevention.
Thanks very much. And last but not least, Dr. Brown, you're up.
Hi, everyone. I'm Greg Brown. I'm a research associate professor in psychiatry at the University of Pennsylvania and one of the co-developers of cognitive therapy for suicidal patients. I'm a long-term researcher in this area in terms of suicide prevention.
Great, thanks very much. And so I think before we go into maybe a ton of detail, I want to give our listeners a sense of, why are we talking about these 4 treatments or where you bring your expertise, and maybe a little bit about why from the evidence perspective. Like these, and not only are we looking at the outcomes that are shown, but the strength of the evidence and how did we kind of narrow to these 4 in some ways? Because this isn't the entire world of sort of treatments that are out there or that could be helpful for individuals at risk for suicide, but kind of like a why these 4 from your perspective. And maybe I'll go to you, Dr. Jobs, first.
Well, from my perspective, we're looking at randomized controlled trials, clinical designs to look at causality of an impact of a treatment. So these are experiments, and the treatments that we're talking about today have all been proven to be effective for different outcomes, from suicidal ideation to attempt behaviors and self-harm in randomized controlled trials. What I would add is that what we want are RCTs, randomized controlled trials, with replication of similar findings, and ideally an independent validation, that is a researcher outside of the developer finding the same findings. And so there are other interventions, but these are the ones that really rise to that highest level of rigor in terms of RCTs, replication, independence.
Yeah, I think that, there's a couple, there's sort of three criteria that I'm hearing, and there's other ways that the evidence can come to be, but we're really having maybe like a narrow view of like the top tier. This has really been studied very well. And I think from any of our other panelists too, are there any other thoughts you have about that? And why is that so important for treatment in general, but for treatments focused on preventing suicide? If there's anything else you want to say about that, I think, because I think there's, from what I'm hearing, it's important that people really understand why it's not everything out there that we're talking about. It's just these really specific treatment modalities. So I welcome the thoughts from others about this evidence question.
Yeah, I would add to what Dave said. It's not just about continuity of findings, but it's about continuity across different clinical contexts, different samples, different populations. And also, I think many of these interventions have found consistent findings across both thoughts and behaviors. So changing suicidal thinking as well as changing suicidal behavior.
I'll just add to that that these treatments focus on suicidal behavior, suicidal ideation, non-suicidal self-injury behavior, which I think was groundbreaking because I think up until before these treatments were developed, psychiatry often viewed the behavior or the ideation as a symptom of an underlying psychiatric disorder. And in these treatments, we're focused directly on changing the behavior, changing the ideation, changing the non-suicidal self-injury behavior. And I think that is a basic paradigm shift that has occurred.
And I believe we're starting to see more literature and research on the dissemination of some of these models of treatment, and that is also quite important. If we are only finding evidence for them within these, relatively small scale, really tightly controlled research trials, it's going to have less impact on the people who are suffering with suicidal thoughts and behaviors if they can't receive this treatment in the environments in which they're treated. So I think research on dissemination and implementation is now the next stage of research for all of these treatments.
I'll come back to that one. I think that's a really good point. I think I want to draw a little bit of a distinction that we sometimes hear if I'm working with health systems or maybe provider groups, and there's the sense of there will be these treatments, but there's also these what I'll just call sort of briefer interventions. And I don't want to say it's reluctant, but there's something about getting past those that I think people need some help with. And so I wanted to start to unpeel that onion a little bit by, what's the difference between these treatments and something like collaborative safety planning or addressing lethal means with an intervention of some kind there, or others that aren't, whether it's because of the evidence or the outcomes we're after, like where does this sit in the context of those other clinical activities we should be doing to care for people at risk for suicide? Just to draw the lines a little bit so people are seeing this in the context of the rest of what the rest of the care some people might be getting.
I guess what my reaction would be that we really do like safety planning type interventions, and we really do like lethal means safety, and we really do like different screenings and assessments, but that's a part of the process and not the entirety of the intervention. So I would separate out acute stabilization interventions that involve like 988 Lifeline or the text line, lethal means safety, and safety plan type interventions as a way to stabilize somebody who's acutely distressed, but you're not really treating what causes somebody to be suicidal. And the treatments that we're talking about today really go to that. They really go after ideation and behavior. And what we've seen in the zero suicide model, and we wrote an editorial about this recently, is that in the model, we did a Columbia, we did a safety plan, we're good. And that is good, but we need more. And that's where this focus on treatment, I think, is so important and something that we're really trying to emphasize within the zero suicide model.
I think that's certainly what I observed too, is that it's kind of, and I've seen this in some of the listserv discussions, some of you have contributed to that, this notion of, well, we like identified risk and gave them something where they can help themselves if they're having a crisis, and like we're good, right? Like that's like there's some assumption that they'll maintain like that, but I think from the other direction, someone else has also said to me, well, we haven't really helped them know how to create a life worth living in an ongoing way. They're just they have a parachute when they need it, right? And so I think it's that is really the crux of it, I think, and what I hear a lot about zero suicide implementation, at least. So to your point, Dr. Jobs, I think that's to create an inflection point there where this becomes as frequent or common in the zero suicide space is certainly somewhere else to go with that model
Yeah,
in
and
particular. Yeah,
And
Dr. Miller,
Adam,
go ahead.
I would add to what Dave said. It really is critical not just to have targeted interventions for acute stabilization, like David mentioned, but to have a broader conceptual model that really identifies and shares with someone kind of the genesis about how issues develop over time. How does their history play a part of that? And then how do you develop the skill set and the capacity as you move forward? So it really is a broader conceptualization that integrates those individual interventions into an integrative model that someone can apply in a meaningful way and on an ongoing basis in their life. And so I think that's one of the important differences.
Do you all think that that is important for everybody? Might there be some folks for whom the immediate crisis plan and safety plan is sufficient? They get through a crisis moment and they're good? Or are you suggesting that everybody would need some form of treatment developing life worth living goals?
So I think we're all in agreement that we need to address the vulnerability factors, the risk factors that give rise to the acute risk. And without that, the prospect of somebody staying alive, it goes down. And so the problem is that clinicians, when they apply or implement these treatments, often muddle the acute risk interventions from the more ongoing risk interventions. And so it's really important to be clear about what you're targeting in the intervention.
And I would add that, one size doesn't fit all. We were in a clinical trial right now with Greg Brown looking at adolescents, where a safety planning plus sort of lighter touch might be perfect for certain kids, but a more a bit longer term treatment with CAMs, our intervention might be better for others. And I really think we're at this stage where one size doesn't fit all, and that we're in an exciting phase where our different treatments do different things. And I don't believe there's ever going to be one treatment that does everything. And to me, the real goal will be to have a menu of options that are defined by evidence that patients could be optimally responsive to, more efficient, saving money, that type of thing is, I think, the way to go.
Yeah, and actually, to add to that, Dave, we've had similar results, and so part of with BCBT, one of the things that we found is greater impact and effectiveness with people that are at more significant risk, that have more evidence of significant vulnerability, and that really hints at the idea that you need that broader model, a more integrative conceptual perspective in order to build resilience over time. And that's what that we found a fairly significant converging effect over multiple RCTs now that really indicate that.
In hearing about the ongoing research that's happening across in some of them in collaboration with one another. I don't know if you take pause briefly to just for our listeners and viewers, we talked about BCBT and CAMS and DBT and CBT, like just to give them a sense of a brief flavor of what those treatments entail. It doesn't have to be a full description of time course of treatment or the various modalities. I mean, there's different skills people are learning in those, but to give a sense of what's a part of those treatments, and then to come back to the research piece, what have we been seeing so far that's working in terms of improving people's lives, and the Dr. Rizvi, as you echoed too, like helping them build lives worth living. So I think it's a good point here to say, well, what for areas of expertise, what do those treatments entail? What does that look like? And what might the experience of someone receiving that look like?
So the treatment that I was involved in co-developing, cognitive therapy for suicide prevention, is divided into 3 phases: an initial phase, a middle phase, and a final phase. In the initial phase, a lot of the intervention happens up front. That includes focusing on preventing suicide behavior, informed consent, and engagement in care. People don't come back for the intervention, that you can't treat them. To do a suicide risk assessment, including a narrative interview of an acute suicidal crisis, to do safety planning, do reasons for living using a hope kit, and then finally developing behavioral kind of smart treatment goals focus on preventing suicide. And really what's driving the treatment is the conceptualization of the patient's problem. So if you see a patient as saying suffering from chronic hopelessness, then the interventions target that those cognitions and core beliefs. In the middle phase, you do cognitive behavioral strategies that are classic to CBT, such as thought records, behavioral activation, and so on. And then in the final phase, we do skills consolidation, including a relapse prevention task, which gets patients to do a dry run, a rehearsal of surviving a suicidal crisis, and then wrap things up with focusing on treatment planning and the need for additional care.
Great. Dr. Jobs, you want to go next?
Sure. So CAMS is a therapeutic framework that relies heavily on something called the suicide status form, which is a roadmap that guides assessment, stabilization planning, and then treatment of what we call drivers, which are the problems that the patient says makes them consider suicide. We do this sitting side by side, if that's available. We do it also online, and it works, I think, equally well. But the idea is that the patient is the expert of their own struggle. And so the assessment that we do, especially in the first session, is heavily focused on quantitative and qualitative aspects for them to unpack what it means for them to be suicidal, who, what, when, where, how. And when you learn about that, then you can move to a treatment plan designed to keep somebody out of the hospital, if at all possible. But to do that, we have to have a stabilization plan, which is a cousin of the safety plan intervention developed by Barbara Stanley and Greg Brown, and then also the crisis response plan developed by David Rudd and Craig Bryan. And then we identify 2 problem drivers. So whatever treatments can treat those drivers is what we do. And so like CTSP, we have an initial heavy focus on that first session, interim care, which focuses on crafting the stabilization plan and treating drivers, and then an outcome disposition. And we're seeing resolution across the trials. We have 7 published trials in 6 to 8 sessions. CAMS is much better for ideation. There's some evidence for attempt behavior, but in deference to our earlier conversation, we think it's a better upstream intervention for people who are new at being suicidal versus somebody who's been chronically suicidal with multiple attempts. And that's why I've been excited to work with Shireen around DBT, because there's a nice interface potentially clinically and also in the research that we do, where CAMS might be really effective for people that are early on ideators, where somebody who's more chronic with multiple attempt histories or more chronic personality issues is a much better candidate for DBT. And we're seeing that in the trials, and that's an exciting thing that's emerging in the research that we do.
So DBT, dialectical behavior therapy, was developed by Dr. Marcia Linehan, and it was developed for the folks that Dave just referenced, chronically chronic suicide attempts, chronic self-injurious behaviors by originally by women who met criteria for borderline personality disorder. The ultimate goal of DBT is to help a person develop a life worth living so that suicide is no longer considered a reasonable option. And it does that by providing a multimodal treatment package, which includes individual therapy, skills training, phone coaching or outside of session coaching to clients, as well as a weekly treatment team meeting for the therapist. So one of the original assumptions that Dr. Linehan had was that therapists who are treating suicidal folks need support, and that therefore they need to come together every week to get that support and to get the help working with these really serious high-risk folks. Now, when it was originally developed, it was developed as a comprehensive long-term treatment, originally studied as a one-year treatment, though Dr. Linehan never thought that it should stop at 1 year for everybody, that some people might need more than that. But as a principle-based treatment with multi-components, what we have seen is that it has been kind of broken apart, flexibly applied to different populations, different settings. Specifically, the skills training piece of DBT has been studied quite extensively and in smaller doses in different populations and settings, and with lower risk folks, or even with people who are not suicidal, and have shown to have some benefit. And so I think what we see with DBT is that because there are so many different components of it, and because those components are actually quite face valid, people are really interested in them, that it's being studied now and being utilized all over the place, which is wonderful and also has some downsides, which maybe we can get into later.
Yeah, I think one of the things people will notice about all of these interventions is that there are a lot of overlap in terms of similar elements, common elements that are effective across these interventions. So BCBT really is a modification originally of the work that Greg and others did. It's a time-limited intervention that focuses on building emotional self-management skills, in addition to focuses specifically on those cognitive elements about core beliefs, reasons for living, reasons for dying is a key piece of that. We do a couple of critical interventions around commitment to treatment, commitment to living, in addition to the reasons for living, reasons for dying. We do the crisis response planning and lethal means counseling. We've done 6 trials now. Most recently, we did an inpatient trial. In the brief nature of it is probably one of the characteristic features. The inpatient trial, the average duration of care was 4.5 hours over the course of time, still had significant reduction in post-treatment suicide attempt rates, and also reduced readmission rates, as well as emergency department visits during follow-up. So it really is a modification of the broader CBT approach in a very time-limited way.
I'm glad you went to commonality, because I was trying to listen to throughout about just some common themes, and there's certainly a bit, there's some variance in time course, let's say, but there's a strong notion of this ongoing engagement, providing skills to the people who are coming for care, and the underpinning of all of these is some form of strength of collaboration, which I think, with any of the interventions even we would require that, but this in particular, to really convey the skills and have them absorb what they would need to make this successful, there is this really strong piece of collaboration and knowing what works for that person. And the bridge I'm trying to go to here is, I wonder about, as more work continues to be done with all of these, it makes me wonder about those who have received this care or in the course of developing these treatments. What's it been like for having the role of those who have lived experience or lived expertise, or have gone down this road and received it, and the input you're getting back? I just wonder about that in the space in suicide prevention now, how much that perspective can really help inform what's being done for people at risk. And I wonder about how that's getting folded in, or how if you have a historical perspective of how that was done in terms of the development of these treatment modalities from a broader perspective. So I welcome anybody to hop on that one first, but you're really making me think about that through the lens of the collaboration. That's kind of a requirement of all of these.
Yeah, Adam, I would tell you it's been critical in the development of BCBT. I mean, each and every time we've done a clinical trial, we've done focus groups and feedback and get feedback specifically from participants in care and look at what works and what doesn't work. And we've made modifications over the course of the years. If you look back over the course of the last 2 decades, we've made significant modifications based on feedback. That have influenced not only what we've done, but why we've done it and what the broader model and perspective really emphasizes. So it's been a critical piece of the development of the care.
Great. Others?
I would, so when Dr. Linehan developed DBT, starting in the 80s, nobody was talking about personal experiences. And not only that, I think there was a great stigma against any researcher having personal experiences with the problem that they were addressing in their work. But of course, now with the publication of her memoir, with the New York Times article that about Marcia Linehan, it is now widely known that she herself was chronically suicidal, self-injurious, and the treatment that she developed was born out of her own experiences. One of the reasons why she didn't come out with that for a long time in a more public way was because it was really important to her that DBT stand on its own evidence before she do that. So she felt like she couldn't share that about her own personal experience until there was significant research supporting the treatment. But in addition to that, in terms of not just, her own personal experiences, DBT, like all the treatments here, were born out of an iterative process with folks who were suicidal. And the treatment got refined over time based on what was working or not working. And so I think those early treatment development experiences are of course informed by people with the personal experience with the patients themselves, and that leads to a more effective treatment.
What I would say, I would just agree and to say all of these, these are close friends and collaborators of mine. Greg was a big influence, and Marcia was a big influence in my getting into the treatment research world. And these treatments do evolve. We grow from what we learn from the patients very directly. As a separate consideration, in my lab, we've been doing now a new line of research with people who have lived experience and asking them, what from your experience do you think about in terms of these issues? So, for example, one of the things that for me has been a struggle has been that CAMS has not reliably reduced suicide attempt behaviors. In fact, we've had randomized controlled trials where it dropped ideation like a rock in overall symptom distress and increased hope and decreased hopelessness, but didn't necessarily move the needle on suicide attempt behaviors. And in the course of our research with lived experience folks, we've talked about that, and they will say, well, why is the field so hung up on behaviors? Which is interesting because I'm really just suffering and struggling, and that's much more important to me. And of course, all of it is true, and we need all the treatments because, of course, we need to reduce attempt behaviors and ultimately completed suicides. But I think, and I've been trying to make an argument for this, and I think everybody's sympathetic to this perspective, that we've got 16.6 million Americans with serious thoughts of suicide in the most recent data from SAMHSA, which is a massive number of people. So I've been trying to make the argument that reducing suicidal ideation in and of itself is a legitimate treatment target, as well as attempt behaviors and self-harm. And because we have 16.6 million, we need all of these treatments and probably more to really put a dent in the suicide challenges that we face in the contemporary clinical care.
Dr. Brown, anything else to add to that part of our discussion?
Yeah, I think that one thing that's common to all of these treatments is the focus on the patient experience and what the people with lived experience bring to the table is the amazing connection that they have with the person who's telling their story, and could really connect with that person and understand what they're going through, convey that understanding. And I think that's really critical for all these treatments. So the more you understand the patient from their perspective, the more that you can, as a team, choose those treatments, those strategies that are going to be most effective for that particular individual.
Thank you. I think as I'm listening and recalling some earlier comments too, so all these treatments have evolved and will continue to evolve over time with input from those who've received care and with specific focus perhaps on lived experience and expertise. I wonder about, well, and then there was a prior comment too around how are these treatments working across different populations and how are we going from smaller studies to a broader audience? It made me think of a question that Dr. Brown, you had raised at some point earlier. If we're thinking about these growing and these will continue to evolve, when we want these to meet the needs of a broader population set, I think Dr. Brown, you asked, like, are these for it? Are we good with these four and it's about scaling these four, or is it about looking down other avenues or different ways of thinking about treatment and pursuing evidence there to get to more options? Or is it like we're not far enough on with these four, let's focus on these four and a few others, let's say, or whatever, however we would define it in that moment, and not try to open up new pages of different books to try to look for other options at this time. I just wonder about your perspective on that in terms of how things have evolved in the treatment space.
So I think when we were initially developing treatments, we sort of worked with therapists who we hired to do the intervention, who we trained, who we monitored, and we weren't really paying attention to what therapists in the real world were doing and their perspectives. And now I would say, as we continue to develop new treatments or modify the existing evidence-based treatments, we really need to understand some of the barriers and facilitators for implementing these treatments in real-world settings. And it opens up a whole realm that Shireen was talking about earlier about really applying implementation science principles to getting these treatments out there to the masses. I know, Dave, you have some pretty strong opinions about this. I'd love to hear them.
I mean, the research we've always done has been effectiveness research. So we've always gone into real world settings and taken the clinicians that were there and trained them in the intervention. So we kind of skipped the efficacy stage and just really went into either hybrid or effectiveness-based studies. So yeah, I feel actually quite strongly that these things live in journals or in books, but don't translate into clinical practice. It's nice, but it doesn't really make the difference that we aspire to make. A couple of things that come to my mind. All of our treatments, I think, do a version of educating the patient to become their own suicidologist, that they don't become suicidal or have a crisis out of the blue, and or an event out of the blue. Chain analysis does a version of that. The suicidal mode model does that. CAMS does that. We're really keen for the patient to learn, how do I get in trouble? And if that involves dysregulation, which it typically does, then we know prefrontal cortex engagement is actually disengaged. So a lot of what's common across the treatments are interventions that are going to re-engage that prefrontal cortex to downregulate. And so these are really effective. We've written papers about the common elements, which I think is exciting. But if we don't actually get clinicians to change their behavior, we're going to keep on defaulting to what I would consider like actually a medieval model, a hospitalization, custodial model, where we know what's best for the patient and we'll lock them up or we'll medicate them or we'll do things that don't have as much evidence base until they come to their senses and they're no longer suicidal.
And I would really like to see the emphasis going forward be on improving the quality related to this, the quality of the delivery of these treatments. So, people can get their mental health treatment in so many different ways now. There's app-based therapy, there's telehealth, there's AI therapy on the horizon. people who provide the therapy range from BA level folks in hospital settings all the way up to doctoral and PhD and MD level folks. And we really don't know really well, like, who are the people that are skilled or can be skilled at delivering these treatments. I think we have, or people who seek out therapy have this belief that anybody they see could do anything, and that's really just not the case. And so I feel personally hurt when I hear somebody say, "Oh, I got DBT and it didn't work," or they got DBT and they said something that they received that was clearly not DBT. And to me, this is a crisis in the field. Like, how do we make sure that these treatments are being delivered skillfully by competent people who are getting sufficient training and supervision in these treatments in order to have the most impact on the people who are suffering.
And to punctuate what Shireen said, yeah, we found the same thing, that fidelity of delivery is critical. That if it's not delivered with fidelity, you don't have impact. And I think that's one of the most significant concerns.
But a really critical point is, how do we convince healthcare systems or judicial systems to provide the training to make sure that these clinicians are trained to competency so that they can disseminate the intervention? What can we do to foster more resources for training and implementation? How do we convince these healthcare organizations to do that?
Well, what I would say, Greg, is that there are big challenges, and not the least of which is a way we've always done things, which is to think that a person who's suicidal belongs in the hospital, or that they should get medication, which can be helpful in some ways, but not like the interventions that we're talking about in comparison. And then the fear of liability. I mean, that tail wags the dog of so much of what clinicians do in the real world. And the fear, I think, is far beyond what the reality of it is. If you're using evidence-based practices and you're documenting that work well, the threat of malpractice litigation plummets. But the fear that I'm going to get sued if I don't hospitalize somebody ends up then driving a lot of clinical behaviors that I think are really not in the patient's best interest. And to me, that's one of our biggest challenges, why people are not in taking these treatments and working with these treatments, is because we keep on defaulting to an old model whereby we think somebody should be in the hospital, we can't skip that step, when there's clear evidence that post-discharge from the hospital, there's increased risk. So that's one of the big challenges I think our treatments face.
I think that to get back to Greg's question, which I think is really important, in my experience, it's not the training, it's the implementation and it's the sustainability. So I'm sure many of you have been in this situation too, where, a system comes into some money and they say, okay, we want a training, come and train our group. And so you go and you train their group, and now everybody can say, oh, I've been trained in DBT by this expert in DBT, but then there's no system level approach to how do we make sure that they're now using this, that they are doing it with fidelity, that we are continuing to improve. So the emphasis on sustainability, I feel like, has not been present in my experience. And then we, of course, also have the problem of massive turnover in these systems. And I think that's a problem we have to figure out how to solve. As you go in and you do training, and the next year, less than 50% of the people that you trained are still in the system, that has huge implications for sustainability of these treatments in different settings and systems.
Yeah, I think I heard a few themes out, and Dr. Jobs will come right back to you, but it's a bit of like, even if we get at the workforce development piece, a barrier can be the liability piece. Is the culture set for them to do that? And is there a system in place to make it easy for them to know when they're supposed to do this with this person and exercise those skills? But Dr. Jones, let me go back to you, and then we can go to some other thoughts I had too. But
Well,
go
one of
ahead.
the things I learned early on from Greg was, the importance of integrated training, and what the research shows is that training at people didactically doesn't change clinician behavior. So I think all of our treatments involve role play training. They definitely involve consultation teams. They definitely involve a content level of engagement, but also behavioral rehearsal. And that's how you can change clinician behaviors. But Shireen's point is absolutely right on the money, which is that sustaining that and the drift from that over time is a huge challenge. So clinicians prefer to be trained at to check that box, but what we're talking about is changing practice behaviors for the good of the patient, and trying to sustain that or attenuate that over time is our inherent challenges to the whole undertaking.
It's almost like if you get invited to go deliver or to train some clinicians in a health system, you'd want to know, like, can you please show me how you're going to sustain this? And what is your operational plan to make this stick at least for 2 years, acknowledging there may be some turnover? Like, make it the case where this is going to be worth everyone's time in some ways.
Well, and for me, I think it also speaks something that I've been really interested in and working on is how do we get people trained in these treatments, in treating individuals who are suicidal as early as possible in their training. I think that that's where, if you're learning it in your grad school program, I think it's going to have, I mean, this is a hypothesis, but I think it's going to have more impact on sustainment than if you're out in the field for 20 years and then you get trained in it, because that's a lot of new learning and a lot of unlearning of what you're used to.
In this sustainability piece, or I don't know if it's that selling health systems that they have to have that in place or be thinking about that first for this kind of treatment. I wonder about, if we thought about some kind of medical procedure people were getting trained in, my assumption would be there would be plans to make sure people have ongoing training or support in doing that, and it's not a one and done, and that there's systems in place, probably including billing systems, to make sure things actually happen in the standard of care that aren't, there's not it doesn't feel like there's as strong a parallel for that in this space. And I wonder about that from a policy level of a way to support some of that implementation fidelity and actually sustaining some of this. I wonder what your thoughts about that, or if that's a useful comparison or not.
Yeah, I actually, Adam, I agree with you completely. This is unique to mental health care. You don't see this in any other area of healthcare where there's not uniformity in approach to targeted problems. So it is, and actually, when you drill into it a little bit and look at it from that perspective, it's a little bit surprising that there's so much variability.
I agree wholeheartedly. Could talk about this for hours on end. When I was treated for early stage cancer a few years ago, I knew that my doctors were doing everything according to the plan, right? And I had great confidence that that the research was guiding every step along the way of that. And I didn't have to question, oh, are you putting your own spin on something? I just knew that that was happening. And I agree with you, David, that this is seemingly unique to the mental health field. And maybe it goes back to the days of Freud where, creativity was encouraged and supported. And I feel like every clinicians are often trained to think that creativity is good and valid, and somehow that following a manual is simplistic and below their pay grade. So I think that this is another aspect of this field that needs a course correction. How do we teach people that actually following the science, following the manual is the most important thing that you can do initially, right? Only when that fails do you consider other options.
Well, it feels like there's so many places to go from here with that. But I think as we started talking about systems partway through our discussion today, and I think, with if a system has been or has the resources, or maybe has been convinced to put some time and resources into this, it feels like the next level of this is making the case for them to ensure they have these something in place to make sure all of this sticks to make it worthwhile, the investment. And I just wonder about, what do you feel like the new or different or sustained arguments should be, or doors we should be knocking on with health systems to really both be thinking about it's worth the time to do this and you should make sure it's done by the book, and have a plan for sustaining this, otherwise it may not be worth your investment. Is that the right way? We're not sitting here talking with health systems leaders right in this moment, but in that scenario, is that part of the argument to make to try to sell them on this a bit more?
I think you look at, I mean, you can certainly look at cost implications for all of these treatments. If you don't want to do it because it reduces suffering and improves quality of life, you can do it for financial reasons. I mean, I think there are enormous financial gains to effective care. I think we found that in our work. I know, Dave, you and Greg have found similar results in terms of reduced need for, for readmission, for ED visits, for all of these things are really significantly costly elements of care. But most importantly, it improves quality of life and reduces human suffering.
Other thoughts on that? Yeah, go ahead,
I
Dr.
think
Brown.
the field is evolving with regard to ongoing quality and how we best do that, and whether or not we can somehow glean from the medical record, maybe using natural language processing, machine learning tools, or use other types of tools to monitor what is said in the therapy room to provide ongoing feedback to the clinician, is where we're currently investing a lot of our dollars.
Perspective I can bring to this is process improvement efforts to go into a system of care and try to raise the standard of care across, maybe even across different domains, and having real challenges with that.
Yes.
Where you have a leader say we're all going to do this, and the leader clearly is giving a clear charge for everybody to do this, and then there's pushback, frankly. And so we actually moved to a counterinsurgency model, which is a military metaphor for going where we're wanted, having success, and having that success propagate out across the system. Where, hey, I want to do what they're doing over in the step-down unit, as one way to go. The other thing I think about around the sustainability piece, which is so important, is to get beyond a one-and-done kind of mentality to the idea that we need booster training. There's advanced trainings. One of the things we try to do in our training model is to develop internal champions, and have the clinicians in that system put their fingerprints on this so they feel like they're a part of the solution. And then they can become internal leaders to maintain the adherence to the models. Because all the work that we do to prove these things are effective doesn't translate if we don't actually do the things that we know are effective.
I mean, to me, there's this sense of, at least, and having talked to systems working with the zero suicide model in particular, people latch onto the clinical components because they see how those could work and that maybe feels the most familiar. But there's this sense, what we're talking about now, there's a big piece of maintaining organizational change that I feel like people think about that for things like screening and assessment, and we can put those in the medical records, so you have to do certain things to advance an encounter. But I don't know that the same level of thought has been put towards what is the organizational change supports for the treatment part. It's like we can build all of this in to make sure people follow the right steps for everything before the treatment, and then it's like we're going to train people to do this, and they're just going to like do this when they're supposed to do this. But the same sort of structural support isn't built in the same way. And I think, to your point there, Dr. Jobs, that's both from the ongoing training and figuring out who the champions are and who's going to echo the message and who the exemplars are. It's almost as if the treatment element of the framework should have its own organizational change plan, because the sustainability piece is really important. Not that it's not in the other places, but with the clear investment in resources for something like this, it sort of warrants having your own separate organizational change plan for the treatment part of the framework in some ways.
Well, I would say that's, Adam, that's where policy comes in. So the new national strategy that was rolled out in April at the White House has a strategic focus on community-based care and on treatment and on evidence-based care that's suicide focused. We had the conundrum of to maintain a business model, we've got to have full beds on inpatient psychiatric units. And that may not be in the patient's best interest. So we're trying to change the tire on the car while it's moving. But I think it's moving in the right direction, which is that the vast majority of people that are suicidal can be effectively trained with evidence-based treatments that are least restrictive and cost-effective. That's done on an outpatient basis. And I think that's a really exciting development, but we still have to transform the business model to make it really sustainable.
Yeah, I think that looking forward with the national strategy and beyond, and even prior to, what is that policy case for this? And I think just keeping an eye on the clock. So we talked about systems, and that's a big boat to turn, especially if we're looking at financial models. But I wonder about, you've all sort of said we've gone in and done the research, and we're talking to both people who are at risk and those receiving care, and training clinicians. Like, you've all done that. I wonder if we might just wrap it up with with everything we know about some of the barriers that an individual might feel about this, how do you kind of go to what would you say to the what's in it for me for the individual clinician who's wants to get better at what they're doing, but maybe has some, either it's a cultural piece, a liability piece. If you're going to give them sort of a parting, here's why this is worth your time from my experience with my treatment modality or otherwise in the collaborations you've done, what might that be? I know that anybody to go first.
Yeah, I'd say pretty simply because it works. Because it actually, all of these approaches make a difference. They work. They improve lives. And it's not complicated. I think maintaining, training to fidelity and maintaining fidelity over time is not an overly complicated, difficult thing to do. It really just takes discipline and commitment to the process. And like you said earlier, Adam, to really create a system and a structure that allows for that. And as Dave mentioned, having policies in place that guide that and reinforce that and emphasize that.
Great.
I agree with that. I would add that, not everybody wants to work with people who are suicidal. And I think that's fine. Of course, if you don't want to work with people who are suicidal, then, figure out a way to not work with them. But if you are working with individuals who are suicidal, we're talking about life and death matters here. And I think that really requires you as a clinician to go deep within and say, how do I get as skilled and competent as I possibly can be working with this population? It's imperative, I feel.
Yeah, I think at the heart of this is being comfortable working with suicidal patients, individuals, and learning what the treatment offers to help clinicians feel at ease, which is very difficult to do when you're going from suicide crisis to suicide crisis. But there has to be something about these treatments that end up impacting the clinician so that they're more willing to treat patients who desperately need this care. I think, Dave, you may have some comments about that.
Yeah, we had this crazy disconnect between people assuming that mental health professionals know effective care, that they're expert in treating suicidal risk. And that's in fact not the case. And we default to a custodial model that relies overly much on hospitalization and medications that have either mixed, limited, or no support. So I've been trying to make the case and been publishing papers along the lines of you can actually do effective care, decrease your liability, practice ethically, and make a difference in a life-saving intervention. And what's not compelling about that, because we're really talking about life and death here. So what I'm excited about is a panel like this where, one size does not fit all. And we're at the cusp of a point where proven interventions can be broadly disseminated if we can get clinicians to use them and systems to support them to decrease massive suffering and save lives.
Mm-hmm.
Well, Perfect. I think we'll leave it at that for the time we have, but I want to thank all four of you for your time and sharing your thoughts and expertise and being so generous with that. So we appreciate you very much, and I think that'll conclude our panel. So we appreciate you, and thanks again. Thank you again for joining, and you can find out more again by visiting zerosuicide.edc.org and also join the Zero Suicide listserv at go.edc.org/ZS listserv.